Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, backtable.com, and wherever you find your podcasts. This is Aaron Fritz as your host this week, and I'm very excited to bring on our special guest once again, the BackTable host, for another special survey episode. Welcome, guys. Real quick, let's go around and just introduce yourself. Tell us where you're at today. Sabine.
Hey guys, I'm Sabine Dond. I'm actually at the hospital at PIH Health in LA. So coming to you live from here.
Mike.
Michael Barraza, Baton Rouge, Louisiana. The Michael Barraza, Baton Rouge.
Chris.
Yes. Chris Beck. I am in New Orleans, Louisiana. Rainy afternoon. Coming to you guys from the NO.
Yeah, we got a bunch of rain today in Dallas too. A bunch of thunderstorms.
It's crazy.
What's rain?
California, or
I don't think I've seen a raindrop in LA.
the radiologist reaction
2 years.
I literally have no idea. It could be hurricanes outside of it. I have no idea because there are no windows where I work. In the IR department.
Yep.
It may have rained here. Who knows?
So I am going to screen share our survey results from the complication survey, which our guests may remember from about a month ago. We put out to see kind of, to get some information about how, can you guys see this?
Yep.
What was nice about the survey is we kind of changed it up a little bit. We want to get some more information about our audience and the people that tune in. So the first question was, describe your current position. And we got 54 responses. So the first, attendings made up about 72%, which is great. It's kind of what we imagine our audience is made up of. Residents was about 13%. And then we had, some trainees, a phlebotomist, an interventional radiologist.
What's phlebotomist?
Good that we have that.
What?
That was you, Michael? You're the one interventional radiologist?
He said
That we have a physician assistant, a phenomenal vascular
that's got to
surgeon.
be my guy, Brian Fisher.
Yeah.
That's
I
awesome.
think so. And then some nurses. So mostly it sounds like attendings, but we're not quite sure if this is all IR or vascular surgery or cardiology or, a makeup of all three of those. Current work environments, hospital was made up the most of it. Academic settings made up about a third. Private practice was about a third. And OBLs was about 13%.
Wow.
And then we had one VA person.
Nice.
How many years out of training? So let's see, greater than 10 is about 30%. And 6 to 10 is 13%. 3 to 6 years out is 15%. So a nice variety here.
Pretty nice
And then
and spread. Yeah.
Yeah. Nice.
Yeah,
cross
pretty even
section
spread. It's nice.
of seniority.
Right,
Yeah.
exactly. And then, so here's where we get into the meat of the survey, which is all about, we wanted to get some information about complications and kind of talk about that. And just to let everybody know, we're going to talk about the survey on this episode and talk about some of our own personal experiences. But we are planning on having some of our own mentors and guests come on in the following months to talk through some complication stories, much like the episode that we did with Maureen Cohey and Sonny Bagla about a year ago.
It was amazing.
Where we did that. What'd you say, Mike?
Amazing.
Great episode. And as you can imagine, I think it led a lot of people to think like this should be talked about more. And I think we can all agree, and we'll see from this survey, everybody agrees that we should be talking about this stuff more. So let's go ahead and jump into the meat of the survey. How many major complications would you say you've experienced in your career? Okay. So we define this as a treatment-related adverse event requiring further therapy with an increase in the level of care or prolonged hospitalization. which I believe we got that definition from SIR, right, Chris?
Yeah, I think we borrowed that nomenclature from the classification system for complications.
Yeah.
That's
So,
sound like something we would have made up. And I'm looking at it now. It's pretty close.
So here was Michael's response.
Yeah.
Never have I ever. And then, including pneumothorax, it's a lot. I think we could all say that.
Yeah.
Right, for pneumothorax. Greater than 25. That's a good amount. That's probably our more seasoned docs, hopefully. It was at 4%. 16 to 25 was 13%. And, the lion's share was people having 1 to 5. And I think that corresponds to our audience tends to be like that 0 to 5 years out. Wouldn't you guys say?
Yeah.
I guess.
I
And I find even like when I filled this out, I think that I selected maybe 1 to 5 or 5 to 15. But like, as I'm kind of thinking about it, like, getting ready for this podcast, I think you just have either like, I think some people's personality, like you kind of suppress some of these complications, I think anyway, but maybe I know there are a handful that stick in my mind, but there are a lot that kind of came to my mind as I was thinking about stories that I know weren't on the forefront of my mind when I filled out the survey.
Yeah. And you also have to, I basically categorize differently complications based on clinical scenario, because we've all been called to do procedures as last ditch efforts. It's part of our job as interventional radiologists. And in some of these patients, a good outcome would just be a Hail Mary. We're any number of scenarios where you're asked to do a procedure where, it's just kind of like the final thing we do to see if we can save the patient. And sometimes those, I see those complications as different events than I do, the ones that happen unexpectedly on a young, healthy patient that is either an unfortunate circumstance or an error on my part.
Yeah. And I'll also compartmentalize mine. Like I was thinking about one as we were coming on the podcast, where it's like a 2-centimeter lung nodule, guy with renal cell mets, biopsied, massive hemoptysis afterwards that then went on to have a pneumothorax, and he had like a prolonged inpatient stay. But there wasn't any, like when you look back at the case, there's not anything I could have gleaned differently or anything I would have really done differently. And so like in my mind, I compartmentalize that into like, not a lot to glean from that clinically. And that was just, the cost of doing business.
Agreed.
Yeah. I mean, I think there's 2 kind of categories of complications. Is the complications like that definition, and then the complications that are, really change the course of that patient's care, right? I mean, like yours back, that happened, and I'm sure the patient did fine. And, the hospital was prolonged, but did okay. But then there's some, each of us who know that maybe you caused some major morbidity or mortality. And those are the ones that you probably remember selecting 1 to 5. Those are scary.
Yeah, I agree.
Yeah. I mean, you always remember the people that have, that where death occurs. Other things. I mean, you guys see, Mike, you and Sabine are treating stroke patients. So, that gets tricky because those are a lot of those are Hail Marys, right? I mean.
Yeah, that's, I struggle with that a lot because, the big thing that we see after stroke cases, and it's almost, it's really hard to predict, are people who get bad brain hemorrhage. And I remember the first one I ever did, I was so proud. I nailed it. I got just an absolute perfect angiographic result. And I was just swimming in self-pride. And, I go check on the patient the next day, and he's just like comatose, and CT, there's just this massive hemorrhage, and the guy died. And that's one of the hardest things about doing stroke cases. I love it, but it is just so hard to predict, who's going to have something like that happen. It's, and then when it does happen, it's rarely is it something you did wrong. It's just how this person, I mean, a lot of it's case selection, but a lot of it is also just how that person responds to your procedure.
Right. Yeah. And so that jumps into our next question. How many of your major complications resulted in death or severe morbidity? About a third said none. So I guess they were, most of these who they were talking about were basically, basically pretty much prolonged hospital stays or complications that led to further procedures. Severe morbidity, I guess we talked about stroke being one of them, paralysis. What other examples of severe morbidity can you guys think of?
A lot of times I think about like, Sabine, this must come up like, with revascularization procedures, like loss of limb or maybe not, maybe not the whole limb, but maybe if you lose a toe or something.
Oh yeah. Yeah. I mean, I think, you kind of have to set, expectations. Like, I mean, you were talking about stroke, Mike, and then in revasc, I mean, it's, it's about setting the expectations because you're going to lose some stuff. I mean, and part of that is part of the procedure. I guess it's part and parcel of the procedure, really. The toe might be already gone, so that's going to get lost, but a patient might conceive that as a complication.
So let me take a second and ask you guys a question, because something that I have struggled with is, and something that has changed, I would say struggle, something that has changed a lot for me in the last 8 years or so is how much of this stuff of potential complications I present when explaining a procedure to a patient. When I talk about a stroke, I'm very clear about that, there's a high risk of hemorrhage and I can't tell you if it's going to happen or not. But, there's certain complications that come up so infrequently. I try to be clear with patients, but I don't want to tell every patient, hey, I'm going to be doing a epidural steroid injection. One of the risks is death. Sure, somebody's probably died from that, but, I'm not planning on that happening to me.
Yeah, that's a good question. I admit, I just talk about the most common complications out of my procedure. If it's an angio, I talk about groin hematoma and infection or something. Pretty quick review of complications when I talk to them.
I mean, I think we could do a whole podcast on the consent.
Great idea.
But I'll just, right. That is a good idea. I'll just share my experience in that I usually, anything that's like written on the paper, that we have some pre-filled consent forms, or like if I thought enough to write it in, I usually mention it. And then, it's kind of fingers crossed that the patient doesn't want to drill down on that thing that's just so uncommon that, it unnerves them to do the procedure, which can happen. But really, I'll say all of them relatively quickly. I'll drill down on the ones that are the most important for lung biopsy. We have death included in our informed consents, because I don't know if anyone else, this is probably a good complication to talk about. When you go and biopsy that, just normal looking pulmonary nodule and the patient codes and dies on the table. And so going back to that informed consent. So I'll actually say all of those things. And then I kind of have a summary statement that I do a lot to kind of put them at ease. And so this is when the moment, I'll touch them on the elbow or touch them on the shoulder and I say, look, it's a low risk procedure. It's not zero risk procedure. A lot of these complications rarely come up. But the one that we need to be worried about today is a collapsed lung. All the other things rarely happen in our clinical practice.
A lot. You guys change your conversation when it's just a patient by themselves or the patient with a family, because a lot of times it's a family that you have to go talk to when you have a complication, right? So I don't know. I find myself when the patient has family there, I a lot of times will spend more time with them so that the family understands, especially with lung biopsies, stuff like that, because the patient a lot of times is sedated and you're scrambling. You put the chest tube in and you get them squared away, but you have to go talk to the family and really spend the most time with them, telling them what happened and everything, helping them understand that they're going to be spending the night in the hospital and all this. So I was just curious to know if you guys change your consent or discussion when you have other people there. A lot of times it's a significant other. I was always trained to include death. You write death down, right? So that if the person dies, they signed a consent that says that they knew that was a risk, right? Now, in the conversation, yes, you say, hey, look, it's extremely rare, but severe morbidity, whatever it be, loss of limb, paralysis, something like that, or death can happen in any procedure. And so that's the way I always kind of talk about it, It could
Yeah,
be a
it's hard.
drug reaction.
I definitely don't mention death and all, and major morbidity. I don't mention that in all my informed consents. Although I think that is a risk of any procedure. And I don't know. It's just
It's almost more from the sedation than anything, if you think about it, right?
mhm.
It's more from the sedation than like blood loss, right?
But I'm with
Yeah.
Sabine. I don't think I'll actually come out and say death unless it's a procedure in which I think there's a legitimate case, like they're going to be dying.
All right. So this is good. I like this question. How many of these complications did you attribute to your own personal error versus
Yeah,
other factors?
Who came up
right?
with these
Yeah.
questions? That's a great one. Wink.
I think it was, we all did. I think we all contributed.
And I think it takes a pretty humble person to answer that question honestly, right? I mean,
Yeah. I mean, most people, okay. So 1 to 5. Oh, none. Okay. So about a quarter are just, those are our egomaniacs right there.
yeah. I mean,
That's just
Early
that's just
goal.
hitting that button 10 times.
I think, in my personal opinion, the cases that have gone the worst, that have had the worst complications, are really actually come down to my own personal error. I think, some error in the case, and it was not just like a by chance thing. It's the ones I can remember.
I think those are the ones that, I mean, for me, Sabine, like I think there is a negativity bias that sticks with you on those cases where you can go
Yeah.
back and say, if I had done X,
Yeah.
you
Yeah,
could have
you're
gotten
right.
a different result.
Totally.
But I know I certainly can attribute a couple of cases to my own personal error. That's for sure.
Well, that's the way I see it is then by definition, those are your complications. If somebody else was responsible, then, I mean, even if it's like a nurse or a tech, yeah, you're the physician, but it's really their complication and you're helping to try and,
Yeah.
Well-
Well, the other thing is like, it's something that happened that can't happen, like an angioplasty that ruptures and, it's, then it
divides.
goes bad.
Yeah.
So that's not, personal error. You probably would have done the same thing. It's just bad luck.
Yeah, that's how I read it.
Right.
That's how I
Yeah,
read
for
this
the
question is,
point, Aaron. It's your complication, regardless of where it happens. And a lot of you see a lot of surgeons and hospitals in general, are very selective about which procedures they're going to do and on whom because they follow so closely the data, like the outcome data, and you want to have the good numbers for that. That is something that we don't really have as part of our practice. We don't have we don't have set guidelines for percentage of complications, things like that occur. And so we see a lot of patients in dire scenarios and end of life care, where we, as said earlier, we have to do a lot of last ditch efforts, an embolization here. Can you put a drain here? He's septic, something like that. And I don't know about you guys, but like I find myself, at least every other week where I have somebody in my room who, whether or not I do my procedure or not, could die like at any given moment or, could, need coding at that moment. And, you don't want to be the last place that the patient goes. You don't want them coming down there to die. It's like it happens in there.
yeah.
I don't know. Am I the only one who has to deal with that?
No, that reminds me of a story, Michael, that I was telling my mentor.
Me?
I thought I was your mentor. I'm 4 years older than you.
I know. I had to.
So anyway, I was telling him the story about this G tube that it was just a run of the mill G tube. Somebody had suffered from a stroke and needed, failure to thrive. And, I put the G tube in, procedure went smoothly, no issues. Guy goes back up to, he was actually in day surgery. It was actually an outpatient procedure. But he wasn't with it. He had come from a nursing home. And next thing I know, I'm probably doing my, following procedure, and my nurse grabs me and says, "Hey, you're, Mr. So-and-so, your G-tube, he's coding." I was like, "Oh," so, I take my gloves off, and I run up there and, they're coding him. The anesthesiologist who, I knew from the hospital, came out and he said, look, he just, we don't know what happened, but his pressure dropped and, so they tried to revive him and, but I think they ended up discovering that he ended up being DNR and he passed away. And I, went to talk to the family, the daughter and the son, and, they were like, he had just had enough. I don't think it was anything that you did. I think that he was just end of life. And, we're kind of kicking ourselves for even putting him through that, having the G tube done. And I was young, I was a very young attending, like first year out. And I hadn't heard anybody kind of say that before. And I felt so bad that he had passed away under my care. And when I told my mentor about it, he said, Aaron, why did you do the G tube to begin with? You should have talked to the referring doc and said, hey, is this really necessary? And you should have evaluated the patient and it shouldn't have just been a run of the mill G tube. And I, in retrospect, I agree with him. And I think it's hard. You guys know this.
Very hard.
It's very physicians push for they push for it. Families push for it. And they don't know that it's a tough procedure to put people, especially elderly people who are malnutritioned. And it can push them to the limit to death. And so you have to have that honest conversation with them. And, that was the first time, that was my first death that was under my care, immediately under my care. And it made me really kind of push back more on those kinds of cases.
Well, I think that's a tough spot. Like the mentor saying that. I mean, I get that. Maybe in retrospect, that was a patient to push back on. But I mean, I can think about a lot of cases that come up exactly like that. Where, I mean, to suss out like all the social dynamic things could take you potentially hours. And I mean, this is just like the whole issue of practicing medicine is that you have imperfect and incomplete information, and you just have to be okay with that. I think this is a scenario where you could have painted it a totally different picture, and 9 times out of 10 that outcome is fine. So I don't know if that would be so hard about
I
pushing back on the referring doc or the patient's family.
I agree with you, Chris. I mean, it's just how many times have you had that old person G tube and it goes fine. I mean, that's the whole reason they wanted put them on hospice and not with an NG tube down their nose.
Right.
So you do it. And, it's a brutal procedure. I don't know how we get away with putting that, 16 to 20 French tube in primarily, but it's hard.
Well, it's, and I say pushback, but what I mean is actually just have a conversation about it, actually treat it like a consult and not just like another paracentesis on the board where you don't even talk to anybody about it.
But
that's really what I meant. And that's really what my mentor was getting at, I think.
I
That's
see.
a very
and then,
part of our job.
Yeah, I totally get that.
Yeah.
I mean, I think that's like the move towards IR. Can I go back to something Michael said a little bit ago about like our complications don't get tracked that often. We don't have like a set threshold for complications. I think like I look at the SIR forum, I think some guys are getting tracked. Either they track in their practice, and I also get the impression that some people are tracked. Like in the SIR forum, like I feel like I've seen some complaints about pneumothoraces rates. Like admin will give them a hard time about that. But I think for a lot of the common procedures, if you go back and look at some of the SIR guidelines, like the QI guidelines, they will have like complication thresholds. We just usually don't pay it. I mean, those are the papers I often look at to know the complication thresholds. I mean, you look at them once.
My point was that we have less of a choice in ideal case selection in some scenarios compared to a spine surgeon.
For sure.
Absolutely.
Yeah.
Oh, for sure. Yeah. Well, yeah. We can, I mean, how often do you say no? Very rarely.
Infrequently.
You know what I mean?
Like I say no.
Infrequently. I don't do much at all.
Chris, you have a special, your group is special in that you guys get away with, I think, a lot. You were telling me about your call. You compare your call to Sabine's call. Sabine, how many cases did you do this last weekend?
Like 15, 15 or 16 cases.
God. All right, that's true. Well,
I did like
I was going
6.
back. Like I do actually have the benefit of like practicing at 2 different places. One's a little bit more high maintenance than the other. But I don't know. Saying no. I don't even give it a second thought these days. I get the consult. I put my note in. I'll get a call from the referring doc, or I'll call the referring doc. And if we disagree, I just tell the guys, I'm like, if you disagree, put it in the note. I'll be happy to reconsider depending if the clinical situation changes. IR signing off, and then like drop out.
Just drop that mic.
Yeah, I think it just depends on the culture of the hospital
Mhm.
and the people,
And where you are.
in this relationship.
For sure.
Where you are in your career and in the
Yep.
hospital. I'm still new at a hospital. These are relationships
Totally agree.
make. And, it's hard for me as a new person in this hospital. I mean, this is something every single trainee who's listening to this is going to deal with. You go to a new hospital and, you want to make good clinical relationships with these people, and they ask you for a favor on the weekend, and, you should go into that being inclined to say yes, if it's appropriate. It's going to be a whole lot easier for me to say no in 5 years, but,
Right.
Yeah, earn that reputation. Yeah. Yeah, it's totally true. I mean, especially when you're beginning out, you kind of have to be
Yes, man.
yes,
Yeah.
man.
Yeah, I think
That's what we tell our new hires.
Yeah, I think
yes, man.
right. I think like
Okay.
especially when you're a new hire, yes is the default answer. But I will say that I think there's an art to saying no. I don't think it gets taught that well. Like I remember, so I trained at Georgetown, and like they hammered into us like be clinical, be clinical, be clinical. You're not just getting an order, you're getting a referral, you're getting a consult. They hammered it into us, and we would see the patient. I would say no in the chart, and my attendings routinely, I hate to throw Georgetown under the bus, but I think it happens, would cut my legs out from under me, and then we would end up doing the case. And I think that, look, if you're saying yes because you have added information and there's something, you want to consider that maybe a trainee is not considering, or, sometimes referring docs can throw some new information your way. But if it's a no, I think that it takes some resolve to like get comfortable saying no and disagreeing with like other smart people in the room. But I agree with Sabine and Michael on this one, that like when you're coming out, there's two good pieces of advice we tell our new guys is that, your default should be yes, and don't kill anyone in the first year.
Yeah.
I had a complication that resulted in mortality in my first year. Can anyone say that on this podcast?
Yeah. Well, I mean the G2, but that was,
I have too.
but
I have one that, I'll go ahead and tell it, but it still haunts me, and it says a lot about like where I was my first year. And it's just a series of just really bad. And I think some people are going to listen to it and cringe, but that's just the way it is. I was asked to do a thoracentesis on a loculated effusion that really didn't have any business needing to be drained. Patient can't come down. It's an ICU patient, so we go to do a bedside. The positioning's not really great, and like the loculated effusion that we're going for is really not that big. So like that is more of a testament to that. I was just saying yes, and I thought like, what can go wrong on a thora? And immediately clip an intercostal artery going in, and have hemothorax. And I think that a lot of people, like I think if you do enough thoras, or if you're in the business of having like kind of a pulmonary practice, that this is going to happen. Like it's happened to me since then. But what really, like, I'll never forget is like, I didn't have the courage to like tell the referring doc, like, this is now my patient, I'm taking him to angio. I called the referring doc, who was a very nice guy. He's an internist. And I said, I'm going to take this guy to angio. I probably wasn't that firm, but I was like, I think this guy needs to go to angio. I think I need to fix it. He was a very senior guy. And he's like, I think you've done enough. I think I'm going to consult cardiothoracic surgery. Long and short of it is, I just didn't have the guts to like say like, no, this is my patient now. I know what's like the patient needs. Cardiothoracic surgery, who also a good guy.
Crazy.
I know. So everyone decided to sit on it, and it was kind of like this patient like that was kind of like waxing and waning, and then but it was a steady downhill climb, and after 2 weeks they died. And like,
you were fighting a cultural battle there, though. I mean, the fact that the referring physician and kind of that's a tough situation, man.
It was
It was
a tough,
in the beginning of your career to have that kind of
Right.
confidence to then disagree with their referring physician, I think is very hard.
Well, I mean, it was a tough deal. It was a lot of bad decisions that got made, but the thing that really haunts me is, and like that would, I mean, I have to admit that's one of the things that shapes me as an IR doc now. Like if I have a complication, I don't care who it is. Like I'm on that patient, and that's now my patient. I don't need another consult. I don't need someone to put in an order for what I'm about to do. I don't care about anything. I'm just going to do what I think is right. And but that was one of the experiences that kind of shaped me as a young IR doc. I mean, that happened in my first 6 months, actually.
It's a shame that is how we learn so well. It's by the mistakes that we make. It's what I tell my kids. Like, oh, you made a mistake. That's how we learn. And, nobody remembers any cases better than they remember the ones that went poorly, they could do over again. And that's why it's important to have these conversations.
I think, that's why I'm so glad we're doing this. I honestly, we can all say that you learn the most from complications. There are some IR meltdown meetings that are really cool to attend. There was one in Colorado a couple years back and everything. And it's just people show and learn from their own mistakes. And you can really learn from others like that. So those are good ones to attend.
Yeah. The other key thing along that, Chris, is regardless if you obviously you want to own the patient, take care of that complication, but you need to, it's very, very important to communicate that complication to the referring doc, because I made that mistake where I went, handled it myself, involved other physicians, talked to the family, and I completely forgot to communicate it to the doc who sent the patient to me in the first place. And that's a surefire way to burn a bridge or have them lose faith in you for sure, because, they were like, it's like they were completely out of the loop, and I thought I was covering all my bases, and I forgot. It's probably as important as talking to the family. Because the referring doc, they feel responsible for their patient's care as well. So if you don't communicate it, it's not going to look good on your part, especially if things get worse.
Yeah. Communication is hard, and it's also, you're kind of embarrassed, and you don't want to tell. Like we had an incident in our practice where there was a big bleed. It wasn't intercostal, it was pulmonary. But we handled it ourselves, and the patient went to the ICU, but we never talked to cardiothoracic surgery. And overnight, the cardiothoracic surgeon got a call at like 3 a.m. He had no idea about the case. The patient was like becoming just a little bit unstable. And he was pissed the next day that he didn't even know. But, it was like my partner just didn't think to call him just to keep him in the loop. So it's just, because you don't want to tell people like what's going on, especially if you fix the problem, but it's important to communicate and have everyone, because you just build relationships.
For sure. Yeah. It goes a long way in building those relationships for sure.
Yeah. Yep.
All right. So the next question, and then we'll get into some of the comments that people left. How do we think as vascular and interventional specialists, how do we think that we as specialists grade when it comes to talking about complications with anyone ever? So most people thought that we did not talk about it enough. This looks like maybe about a quarter said that we do talk about it enough, and nobody said too much. Reaching out to colleagues, but it was about 50-50. About half of us think that it's enough, and about half think that it's not enough. I don't know. I mean, I think this is something you learn over time.
Yeah.
I think that
it comes down to your personality. I mean, when I have a complication, I talk about it
for sure.
I need to vent almost. I need to be like, yes, like this is what happened, and am I dumb or am I bad? It's kind of like to talk about it.
Right.
Yeah. One of the things I will say is I think like for all the new hire, or really anyone who's out in practice, I think you need to cultivate like a network of people that you can have like a safe space to talk about complications, because
totally agree.
It's not always like that. I don't just go air my complications
that's
to anyone.
Great tip.
Yeah. I mean,
I had that. Steve Young in my first job was that guy for me, and man, he was so vital to me in my first 3 years out. Anytime anything happened, just like I didn't have to, I didn't have to make myself sound good. I didn't have to worry how it came off. I could just tell him like what happened, how I felt, and it was like to me, it was. I needed it, man.
Yeah. No,
Yeah.
that's a great tip. I don't think I've really heard that tip ever being verbalized to people, coming out, being like, look, create a network where you can talk to people, whether it's bouncing ideas or bouncing complications. It might be your fellowship class or it might be some friends that you met at a conference, but that's a really, really, high level tip.
And I should clarify,
I was going to say,
Steve Young, the interventional radiologist, and not the former 49ers NFL quarterback.
Oh, I thought you were that cool.
That would have been pretty impressive.
Either one of those guys, I think, would be good resources, though.
Yeah.
Both nice guys.
Yeah.
but yeah, definitely the people that you were in the trenches with, like my co-fellow Robbie Morrison, we exchanged stories, and also David Field, who I did residency with, but you're right. It's the people in the trust tree, right?
Yep.
That you can count on for sure.
I trust you guys. So,
Not Michael Barazza. Do not trust that guy.
Never.
All right. So, and then, this was kind of one of the things I think Maureen Coey was getting at in her episode, seeking help or therapy to deal with the emotional aftermath of complications. So, as Maureen was talking about, it takes a toll on you, especially when you're young attending or even a trainee, when you haven't had many complications. And it is important to talk to somebody about it. I'm thankful in that I have a wife who is also a physician, and, we can come home and kind of trade stories, and that definitely helps. But, sometimes it goes beyond that, like, especially if you dealt with a death that's you really feel, responsible for, and professional help might be the next best step for that. Basically, the recap is most people thought that we don't seek help enough. This is another really important one, is supporting one another through malpractice claims. Because not only is the event itself crazy stressful, but you have to relive that event through a malpractice claim over and over again. That's got to be super stressful.
No.
And there is a podcast that exists
The L word
out there. Yes, the L word, which is very good. It's 11 or 12 episodes, but she goes through A to Z because she went through the process. She brings on other people who've gone through the process, and really helps de-stress the situation. The L word by Geeta Pensa.
Yeah, I think she's an ER doc and went through a case, and basically she walks you through everything and then talks to experts in the field, like every step of the way, like of the litigation process. And
Wow. That's cool.
oh, it's an awesome podcast. And, just from being in the biz, I'll tell you, I think she does a really good job on production too.
Nice.
Yeah, for sure. Oh yeah, she's really good. Okay, so let's jump into some of the comments that people left. One was in your these are free form comments. In your estimation, what was your worst complication? So we have death. We've talked about. One person mentioned severe hemorrhage after a percutaneous liver biopsy. The patient required subsequent embolization and nearly coded on the table. Had severe hypotension. So that's what, another one of your kind of bread and butter cases that can arrive pretty quickly. One person had a DVT die on the table right in front of me because of me. That sounds pretty bad.
Yeah.
Another PE that led to death. Another comment was someone did the wrong procedure. They did a cholecystostomy tube instead of an internal external biliary drain. That could be pretty.
I'll just say but I'll just say the wrong site, wrong procedure complications, if you can classify them as that, those are the ones that just stick with you until the absolute end. Not that I want to pile on all my complications and terrible things, but I was doing an SI joint injection, and it was for a left-sided SI joint injection. We did the right side. There were a couple of reasons it happened. Like we did a lot of things right to like keep it from happening, but in the end, the wrong joint got injected. And the patient was totally cool with it. I mean, he was like, look, the other side kind of hurts me. I was going to have that one done anyway. But and in the world of procedures, SI joint injections, left, right is not a big deal. But I mean, you know, still, it was very much a big deal in terms of like, that's not the procedure he had signed up for.
Pretty much a year ago, I remember I almost did the wrong leg, unknowingly for a vascularization because, you know, we decided the leg and everything was all set up, antegrade. I mean, when you see it, everything's just kind of draped over, right? You just see a groin. And I was about to stick it. And my nurse is like, aren't we doing the right leg? And I was like, oh, like it was literally as I was about to put Lido. And I mean, that was just like a rush of adrenaline, you know?
Oh my God.
Luckily it did not, but I would have 100% done an angio. I would have found disease on that side and did a procedure on the wrong leg. And just based
Was the
on
patient awake?
patient was under GA.
Oh, good. Well, at least they didn't hear that.
Yeah. But I think that's like,
Talk about losing faith.
yeah, I think that's actually like going back to like how those kind of procedure. I mean, there's a lot of reasons and I think they all have their nuance, but I think one of the ways that it happens with us is that you're thinking the right way all the way going into it. But then when you walk in the room, there's something about the setup that cues you. Like you go into a lot of like muscle memory and you kind of are, you're thinking about like, you know, step 10 or the hardest part that's.
And we even
you
timed out.
Yeah.
We timed out the proper leg and everything, but it's just muscle memory. It's like, okay, you know, everything's fine. Boom, boom. Everything's always fine. But it just takes a small error like that, which, you know, it just would have been so easy to stick the wrong leg. I mean, and you hear about those cases, you're like, man, who would do the wrong side? Who would do that? I mean,
sure.
I was millimeters away.
Yep.
Yeah, if it wasn't for my nurse, I would have done it.
So I'm reading through these, and I think the common thread is a lot of these are just basic procedures that led to major complications.
Good point.
Right? You have bleeding after paracentesis, that, you know, they had an elevated INR led to DIC and death. You have massive bleed following renal biopsy, which also haunts me. That's why I hate renal biopsies.
Hate renal biopsies.
Death after a DVT lysis.
You know, you did say something there, Aaron, and it's that small procedure. You don't think anything bad is going to happen. Temporary dialysis catheter, maybe it goes into the wrong artery, wrong vessel. You might be working fast. That's a major complication on such a routine, again, muscle memory thing. You're going fast. You're doing a tunnel dialysis catheter exchange, and maybe you might suck some air. There these small little things, the routine things that can really just F you.
Some of these are scary.
Yeah.
All of them are.
Lower limb thrombosis requiring amputation. What's the medication ones are also scary.
I know.
Jeez.
How about stroke following routine radial UFE?
Yeah. Radial. Yeah.
TJ liver biopsy tore through IJ and carotid. Oof. Liver abscess drainage that resulted in death.
I think those guys, actually that is a procedure I treat with a lot of respect. Like the liver abscess, I feel like those guys can get sick really quick.
Totally.
Same with your dialysis patients, right?
Dialysis.
Clots. I mean, Lord.
That's mine right there that you highlighted.
Oh, really?
Yeah. So I had a declot patient. If I can just tell it for a second, hero graft. I've declotted it a ton of times. I knew the guy really well. Came in as an outpatient, and I don't know if anyone knows like how those hero grafts work. They're the easiest things to declot in the world. I mean, it's like the simplest procedure. Got it open, and then like I'm like holding pressure like as we're like closing. Code's on the table, doesn't come back.
I think it's the number one. I think declots are the number one code procedure that codes for IR.
I've heard that.
I read that somewhere. It might be a black pearl, but it seems true.
All right. Well, last thing I want to cover real quick is topics on the subject of dealing with or preventing complications that we'd like to hear, that our audience wants to hear discussed on the show. So a few comments here. One audience member would like to hear more about how docs deal with malpractice claims, seeking help for counseling. What are good resources for this? How do you find a lawyer or therapist who specializes in these things? We do have some resources, and we can post those with the show notes.
Yep. Gita Pinsa for Gita Pinsa's podcast. We should we should also get her on the podcast.
That would be awesome.
We should just cover that topic with her. Actually, and then she has great resources. She knows good lawyers and great resources and therapists for that.
Yeah, let's get her on.
An annual Big Three conference on complications and how to fix them would be pure fire. And then talking about complications and how to facilitate an M&M case presentation, but academic and not a blame game or flexing on how you would never do this. Just like a healthy environment. I agree with that. It gets kind of tricky when people get up there and it can be a bit judgy,
Like about that, conference. I mean, there are conferences that and when another one comes up, like an IR or endovascular meltdown, we'll definitely promote it on social media. I'll keep a lookout. Those are my favorite conferences.
Agreed.
And so I will definitely find when one comes, or even help host one in person when that comes back, and make that happen.
So the common thread here with these comments are malpractice, discussing malpractice. So I think that just lets us know that we need to cover that topic, and it might even be a 2 or 3 episode topic. But I think the best way to finish this up here is this comment here. Complications aren't discussed enough, so thank you very much for tackling this. I could easily see this as being a multi-episode topic. We have rare complications in IR, so we don't get good training about how to deal with them during training. Having a good mentor in your practice helps a lot. And I try to do this for my younger partners now that I'm older. So along those lines, that's sort of the plan this fall is to have some mentors and older, more seasoned attendees come on, kind of talk through complications that they've had. And, just carry on the conversation. And like everybody kind of wants to do is have a nice open conversation about it so that we can all learn from it. Any closing remarks from any of you guys?
No, I just was going to say something about how when I have my first complication, it sounds like I'm going to have a lot of good resources.
Nice.
So good. So good.
I mean, I think that's the essence of BackTable, right? We just talk about stuff and in a casual way. So I think that would really, really fit in with our motto in the fall, to talk about some complications from some seasoned veterans.
I think there are a lot of ways we could take this further.
Yeah. I'll say, so my closing remarks are for the younger docs that are out there and some of the seasoned ones. If you have a complication, own it, but don't feel the need to over own it. Don't accept the whole world on your back. I mean, you've had a complication, own it with the patient, the referring doc. And then one thing I always do now, if I have a complication, no matter how small, I call risk management and get them involved. There's a lot of things that they can do on their end to help it make that experience a little less painful for the procedure or for the patient and their family. So that's a tip that was passed on to me early on, risk management.
Yeah, that's a good one. I appreciate that. Thanks guys for coming on. Always good input from the BackTable crew. Thank you to our listeners for tuning in. Again, if you missed it, please go back and listen to the episode with Maureen Cohey and Sunny Baga. That is episode
45,
June 2019.
45.
That's right. Go catch out 45. And we will get some resources added to this one and get you some more episodes around this topic. Thanks again.